50. So welcome to Grand Rounds this morning, this lovely snowy December day. We'd like to start with our land acknowledgement. So Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. We're very excited for Grand Rounds this morning, and our presenter is Dr. Deborah Mervitz, but she's also joined by a wide group of people, which I'll introduce in a minute. So I'll start with Dr. Mervitz. So Dr. Mervitz is a pediatric anesthesiologist and assistant professor at the University of Ottawa, who has 14 years of experience at CHEO. She is the medical director of the acute pain service, where she works with in the transitional and chronic pain clinics, and she has created pain management order sets and pathways to enhance patient care. She also supports OR efficiency with administrative projects and works to optimize CHEO's electronic medical records for APS and anesthesia workflow. And her goals are to improve patient care delivery and support excellence in pediatric anesthesia and pain medicine at CHEO. She's going to present to us today an approach to patients admitted with acute or worsening pain or dysregulated behavior. And there's also going to be a large Q&A where you can see this. So there's going to be Drs. Jovanovic and Risco from psychiatry, the NPs Megan Greenough and Tiffany Amon from chronic pain, Brenda Martelli from APS, and then Kalinda Ramasaran from physiotherapy, and then Daniela Maris and Janice Cohen from psychology. So we're really getting all the expertise. It's amazing to have them all together to present to us today, and I'm really excited for this talk. So over to Dr. Mervitz.
Thank you so much, Donna. Really appreciate that. And I really appreciate that you highlighted the whole group that is here today supporting me. So we all created this together. So I hope that this is able to be interesting and supportive for the audience at these Grand Rounds. I just have to be able to move the slides forward. There we go. So the objectives that we'd like to share with you today are to discuss common concerns faced during inpatient admission of patients with difficult to manage pain. And I do have multiple case presentations of recent patients that we've been exposed to at CHEO to try and get a sense of the fact that this is actually something that we deal with. While it may not be common, it is something that is consistent. To discuss a specific philosophy and approach for supporting patients with severe pain during their admission. And I'd also like to present to you our multidisciplinary-based practical suggestions for inpatient teams to follow that are to support patients and families, but are also able to support healthcare providers. So what is the clinical scenario we're talking about? So at CHEO, we do have intermittent admission of patients who are complaining of new or worsening pain. And we have a large volume of staff. This is not something that happens on a very frequent basis. And so it's difficult for us as individuals or as an institution actually to get good experience and comfort in dealing with these patients. And these admissions can be prolonged. So while we may be exposed to these individual patients, the time at which you might be exposed to them in their process of their admission might also make it difficult to get some expertise for them. For these patients, the purpose could either be pain management or finding a reason for the pain, but it still can kind of get the same approach that I'm hoping to present to you today. And these patients can present with dysregulated behaviors that are present when they say they're in pain. And so clinically, we label these as being a patient in a pain crisis. And with these dysregulated behaviors, we can have very difficult behaviors to manage. So they can be screaming, swearing, they can be physically aggressive for a long time, for over 40 minutes, for hours. And so this is not an uncommon presentation in this patient population. So as you can see on the right-hand side, these will be the three cases that I will be presenting to you today. And they are by they are in no way fully inclusive of all the patients we see, but they are ones that have been recent and that have been very prominent in my mind. Commonalities between these three patients and most of them that we will be exposed to while they're admitted is that they can have neuropathic pain and central sensitization. There can be a delayed start of pain medications that are used to treat this type of pain. And they can also have a prolonged admission duration that's impacted by how long it takes for us to actually recognize and start treatment for neuropathic pain and central sensitization, how long it takes for us to actually get the multi-D approach that I will be discussing with psychological, psychiatric support, as well as physiotherapy for achieving functional goals that can actually support progress and eventual discharge. So we'll start with our first patient, and I have reached out to all the patients and families and had permission to share them with you. This is a 16-year-old who was previously healthy and who experienced an accidental gunshot wound to a left lower quadrant, where the bullet transversed through and went into her spine, where a partial bullet fragment remains at the L3 level, and she has an unfortunate resultant paraplegia. With a penetrating wound in her age, she was initially taken to the Civic Hospital and was in their surgical intensive care unit for 41 days, with a primary surgery of a posterior lumbar decompression from L1 to L4. With a total of 57 days admission at the Civic, and as I mentioned, the first 41, she was actually in intensive care. She was then transferred to CHEO so that we could support her with future care, with an eventual goal of having her admitted to the Blue Review Hospital for spinal cord rehabilitation. And she was at CHEO for about 4 months prior to us achieving these admission criteria. She was a very complicated patient of the Civic, as I mentioned. She had epidural abscess with resultant delirium, and this actually transferred into her time when she was transferred to CHEO. She'd experienced a laparotomy with bowel resection and also had a left ureteric reconstruction. So her course at CHEO was equally as complicated, and it was very difficult because she had the resultant delirium from the abscess. She also had polypharmacy, very complicated patient, and so it was very difficult to upward titrate the medications to treat her neuropathic pain. So as a result, she had the medical complications, delirium, but in addition, we had poorly treated neuropathic pain. And so with this presented itself with her having intermittent spastic movements in her upper extremities, and it was very challenging for the big picture to be elucidated. And so these were unfortunately labeled as functional. However, once we were able to get aggressive medical therapy over neuropathic pain, and we were able to actually minimize the medications so that they were tailored towards exactly what she needed, we were able to actually get on top of and eliminate these spastic movements. Initially, in her time at CHEO, there were multiple multi-D meetings looking for additional tests and interventions to support her, and we were running the risk of getting over-medicalization for this patient, versus focusing on function. But luckily, we were able to go on the latter path. Her duration of admission at CHEO was dependent on the pain medication and actually achieving functional goals. So again, she could meet the criteria for admission to Blue Review. And you can see on the right-hand side what a pictorial representation, this was actually in the patient's room, of what we were going to do and what our goals were with the big team and actually achieving these for her to actually meet admission criteria. We were able to achieve this with optimizing her medications, also goal-based physiotherapy approach, as you can see on the slide, and also, and very importantly, support from psychology to deal with her traumatic injury. And the focus was placed on function rather than acute care investigations and procedures when this was possible, considering her underlying status. Second patient was a 17-year-old with hidradenitis suppurativa. And again, if I'm mispronouncing things, please excuse me. This patient was admitted to CHEO for 36 days. So he was admitted because of inadequate pain management and poor function. And he actually started with having challenges with pain management with the onset of his disease, where he was trying to be supported in the community. And the focus was on long-acting and intermittent release opioids for the initial pain management. This was also started initially while he was at CHEO, and this child was just not progressing. It was very difficult, and that was actually one of the main diagnoses for him, was inadequate pain management. However, we were able to actually change our mindset and change our therapeutic plan to focus on a neuropathic pain model. And once we changed our main therapy focus to Lyrica, where we had a ketamine infusion first to allow for rapid upward titration of Lyrica, and we were able to discontinue the long-acting hydromorphone, we were able to actually get much better pain control and function for the patient. But as we all know, unfortunately, these admissions are often complicated by other concerns. And for this particular patient, there were significant concerns with coping and motivation challenges, specifically with an underlying mood disorder. And he just had incredibly low motivation, did not want to get out of bed, had multiple pillows around him, and he spent most of the day in bed. And so this was very difficult as well to support making a plan for discharge. As well, he had dressing changes. He had significant ulcers. These were very painful. And the anxiety around the pain that was going to be happening with the dressing changes was very limiting for this patient. And for a long time during his first admission and even into his second, he was really asking for IV opioids as he felt they were the only things that were supporting him. We were able to initially be successful in discharge with this new pharmacologic regimen for analgesia, specifically with neuropathic pain. And the dressing changes at home were very stressful for the patient and his father. And so there was ability to put in place community supports for dressing changes with nurses in the clinic. Unfortunately, this patient had required readmission to hospital with concerns of increased pain, as well as patient and parental feelings of hopelessness with the patient's expression of pain. And the father specifically mentioned that the turning point for them for representing to CHEO was that the patient would go into his father's room in the middle of the night, wake him up, and just cry for prolonged periods of time. This was very stressful, and then the stress continued for presenting to CHEO and resulted in admission. Luckily, we were able to get our fulsome multi-D approach with a second admission. We were able to provide discharge within 5 days. There is further supports for the outpatient with mental health, dressing changes, and also providing supports for his father. We were able to optimize medications for his mood, as well as prescribing a PRN antipsychotic to take alongside his PRN analgesic to support the increased anxiety, specifically that was occurring with the dressing changes as well as middle of the night concerns. Our third patient is a 7-year-old who had right ankle osteomyelitis and pain amplification. His duration of admission was 22 days, and the APS was only consulted on post-admission day 8. At that time, the diagnosis was pain amplification and neuropathic pain associated with the osteomyelitis, and neuropathic pain medications were started. And the APS was able to initiate a higher intensity therapeutic plan for his pain after the IND, surgical IND was performed to deal with the infection, where we were able to place continuous peripheral nerve block catheters to support more intense analgesia as well. And as we've already mentioned, comorbidities for patients who presenting with severe pain, anxiety was noted to be present, and health psychology was consulted, where dysregulated behaviors were noted as the patient was uncooperative with mobilization, and he had screaming, swearing as a 7-year-old, so it was quite unusual, and hitting his mother with the boot. So again, the aggressive behaviors. Child life was able to be initiated and supported during physiotherapy sessions, and the initiation of a psychiatry consultation was also invaluable. The team was encouraged to take on a trauma-informed approach, and we will discuss this a little bit later. Benzodiazepines had been trialed to support with the behaviors, and psychiatry suggested stopping these and instead trialing a low-dose antipsychotic medication to support irritability and anxiety. This was felt to be very successful, as our APS notes say that adding that medication improved behavior and the ability to engage with staff. And he was found to have less outbursts and swearing and more engaged, and then less emotional dysregulation. So he was actually able to participate in physiotherapy sessions, which were required to allow him to be functional enough to be discharged. So these are our patients. They were very intense, took a lot of intense intervention, a lot of stress for the patients and family, as well as for staff. So these are just some examples, but what are common themes that we can see with these patients? So the ones I presented and others. It's not uncommon for us to see that there's a reliance on IV opioids to treat the acute pain crisis, and this can come from requests from the patients, but it also is very common that we see this as being initiated by the admitting team. And the IV opioids, they do provide anxiolysis, especially if they've been given as a bolus or a rapid bolus. And these patients often have poorly controlled pain. They're suffering a lot. And so sometimes even just that small amount of anxiolysis can be enough for them to relax. And so it's not necessarily that all these patients are opioid seeking, but just if we understand why this seems to be a common pattern, it can help us recognize them and then put other therapies in place. But it's not only opioids that these patients might insist that only the IV form helps them. It can also be Gravol. So these are often common themes that we see in patients of this subtype. There's also just our standard when we're doing acute care medicine. We've been taught to focus on pain scores, and this unfortunately doesn't work in this patient population. Function is a much better means to follow progress, but just our standard is to focus on pain scores, and unfortunately in these patients it can prevent progress in care. There can often be changes in messaging around the management plan. And this often happens because these are challenging patients. Sometimes what we're doing doesn't always seem to work. And so there can be crises that happen daytime, but also after hours. So you can have a very well-meaning on-call staff comes in, sees the situation isn't good and says, well, maybe I can fix this. But they don't always know the full story because they're just covering emergencies. And so with these patients, a common theme is that there's conflicting messaging delivered by different staff, and this can lead to a lot of distress for families and can actually be a barrier to them engaging in the adjunctive therapies and delays the acceptance of the multidisciplinary approach that I'm presenting today that we found to be the most effective in supporting them and treating their pain. Other common themes is that, again, these patients don't seem to progress in the usual way. We're very confused by them. It's very stressful that our normal approach of testing, diagnosis, therapy, get better, go home isn't followed in these specific scenarios. So we're desperately trying to find out the reason. So we do more and more testing, new tests, but also sometimes repeat. Maybe we missed something to try and find the reason behind the severe pain. We can invite more specialists to support us. And this constant barrage of testing and more specialists can be traumatizing for the children we're treating and for their families. Because whether the procedures are painful or non-painful, the fact that none of them are leading to a diagnosis or a cure of the pain leads to increased fear and distress. And this fear and distress can stall the progress for our patients. And sometimes patients just become dependent on the circumstances of the acute care admission. They don't want to leave. This is a fabulous place. You get your food made for you. You don't have to go to sleep at a specific time. You can lie in bed all day if you want. The stressors that you might have at school or at home aren't present because you're sick and people are treating you well. So these can lead to patterns of movement avoidance that can lead to worsening function and greater disability. So our acute care admissions are really not good for these patients. And as we already suggested, they get a prolonged admission. Other common themes is that these patients and families can have perceived invalidation. We're frustrated as healthcare providers when things don't follow our usual path. The patient keeps complaining of pain and we feel like we're failing them. And so sometimes that expression can come out to the patient as saying, the pain is only in your head. It's a mental health diagnosis. You're not actually having pain. We don't believe you. And whether this is intended or not, this is not an uncommon thing for patients to experience. And they can have loss of faith in the system and also increased anxiety and fear that we're missing something dangerous and bad is happening, because what else could be causing pain of this severity? And so we have to always keep in mind that pain is real, even if, and in the 3 patients I presented, we did have organic pathologies that were associated and could explain the pain. But as you are aware, pain isn't always having a cause that we can find on a blood test or imaging. We can have a dysfunctional or irritable nervous system. You can have myofascial pain, CRPS, central sensitization without an organic trigger that we can find or test for. And so pain is real, and our patients have to understand and know and feel that we do believe it. And so invalidation is common and harmful, unfortunately. So this slide is from our psychologist, health psychologist, Dr. Maris. And she has presenting us with data from a study that says that 99% of patients feel that they have experienced invalidation from their family members, and 95% say that they are experiencing invalidation from medical providers. And we can understand why, because it's very difficult to tolerate a patient's distress when it's that severe and that prolonged. And so the parents might also think, if we don't understand what's going on, why is my kid screaming and the others aren't? My kid must be bad, or I must be a bad parent, and it's very stressful. And there also could be, for that individual patient and family, sociocultural factors and social scripts like, suck it up, our family doesn't express pain, we don't cry. If you're in pain, you just get up and you just move. And we don't tolerate this. This isn't what our family does. And so that can also be inherent, and that can be very harmful for our patients. And then it's also very important for us to understand our own fundamental pain biases, what are our individual blind spots, and even gender differences or biases can play a role here, causing this cycle of invalidation with pain and distress all feeding into each other. And as if the situation isn't hard enough, then we also add dysregulated behaviors onto the mix that express when our patients are having this severe pain. And they're difficult because they cause the patient and caregiver significant distress. Often these type of behaviors are not usual for the patient. They don't actually know why is my child changing and behaving in such a strange way? Why is my 7-year-old now swearing? And again, this can certainly have a concern from the parents that something dangerous is happening. And as we already mentioned, it's really hard for them to see their child in distress. And us as healthcare providers, these are really long and disruptive behaviors sometimes. And so it's hard for the other patients on the floor. We feel responsible for that. And then we feel responsible that this patient is suffering and what we're doing isn't helping. And so then it's not uncommon for the healthcare providers to feel that they're being helpless and being ineffective. So in this terrible situation, what can we do about it? How can we take the situation of feeling helpless, where we don't know what's going on and we don't have a plan, into something where we say we are in control, we understand what's happening, and we have a multidisciplinary approach that is tried and true and that we know can be effective in supporting these patients. And that's what our team has come together to present and to put forward for you. To show that our approach is successful at supporting the patient and family during their acute care admission. It's also helpful for bedside staff, whether it's daytime or after hours, and its basis is in trauma-informed care. And as you can see, all the services that Dr. Johnson already described are present today with the call, who are involved and have been involved in creating this. But it also includes you as the admitting service and consultants, whether it be pediatrics, surgery, because we're all involved in being with this patient's admission and supporting them. So our pain services have created a document with recommendations that I will be presenting, and hopefully we hope to make it into a policy that can be available for all staff for the acute care admission for just kind of reference points, because as we already discussed in the beginning, these patients come to CHEO regularly, but infrequently. So just to try and help our exposure and comfort despite irregular experience with these patients. So philosophically, so I just described how this can be very, very challenging scenarios. So how can we take charge and have confidence and help our patients understand that they're supported and that we have confidence when we're supporting them? So philosophically, an early consultation to our pain service, specifically the acute pain service, for support and guidance on the best analgesia plan. There's multiple things that we have expertise on for guidance. For example, foundational analgesia with regular acetaminophen and an NSAID. And this might seem like a motherhood statement, but it's very common for us to get involved with these patients and have these either one or both of these medications ordered or only PRN. So even this is a small thing can make a difference. We can better elucidate the type of pain present, whether it be myofascial pain, and then suggesting a specific muscle relaxant, neuropathic pain, suggesting therapies there, and also our more intense options for therapy that we have, such as a peripheral nerve block. Philosophically, it's very important that we do an intense time period in the beginning with referrals, investigations for diagnosis and defining the problem. And by diagnosis, I don't necessarily mean that we have to find something. I just mean that we have to rule out the bad and dangerous things or the things on which we can intervene. And that's defining the problem, because even if it's a negative test, that could still be a positive thing. It's important that we do have fulsome communication of ideas and progress to the family, but that is consistent among all our providers. And that with this philosophy that we minimize over-medicalization and we minimize ordering unnecessary tests. Opioids, as I mentioned, it's not uncommon for us to see the mainstay of therapy for these patients being IV opioids. Sometimes they're appropriate, but if you could please allow us to provide that guidance to make a plan to minimize and tailor opioid use to when they can be helpful. And I will review that in a little bit as well. So as we just alluded to, you don't need a positive investigation to diagnose some pain conditions, but the 3 cases I presented did have underlying diagnoses that once we knew them could tailor our therapeutic approach. So regardless of whether there is an underlying organic diagnosis or whether this is a pain condition, the 3P approach is the one that we do propose, because the patient's entire life is negatively impacted by pain, with the severity resulting in an admission. And so our 3P approach deals with multiple aspects of their life. So it involves pharmacologic, physical, and psychological. And through this 3P approach, it's important that we validate the experience of pain and the psychological suffering so that the patients feel heard and know that we're going to be there to support them. It's also important for us to be aware that many of these patients have acute on chronic pain. Often there's a trauma linked to their current or past pain experiences, and it can be like obviously a trauma like our first patient with a gunshot wound, but there can be other softer traumas. Oh, I shouldn't actually say it that way, but there can be other traumas that are impacting how the patient is presenting to us. And these can actually be linked to the dysregulated behaviors. And as I mentioned, the trauma-informed care with communication is very important in this patient population. And it's important for us to use a goal-oriented physical approach, as this helps patients to gain trust in themselves and their ability to manage their pain and functioning at home. And it actually allows us to focus on positive things instead of the constant negative of pain scores of I'm still in pain, I'm still in pain. So this is our philosophy. Practically speaking, how do we accomplish this? Early consultation of our multidisciplinary team of the acute pain service, BNCL, and physiotherapy. Foundational analgesia of regular Tylenol and anti-inflammatories. Some patients will refuse the Tylenol, it doesn't work, but education of these patients that Tylenol and an anti-inflammatory actually have synergistic effects. And when we give them around the clock instead of PRN, you can actually get stable serum levels at that point that can actually decrease the pain intensity. And it's not to take away the pain, it's to lessen the intensity. And so hopefully education can actually support patient compliance. As we already alluded to, caution with opioids. Please allow APS to support how these should be used. And it's very important that we have only one team ordering or titrating the pain medications. And when possible, not to change the pain treatment plan off hours, especially if we're doing medications that are supporting neuropathic pain or pain sensitization, or central sensitization. These medications can take a while to actually get to therapeutic effects. And our pain plan often leaves a PRN medication to take once the pain, if there's any pain spikes on top of this chronic plan. And if we have a disruption in it, we basically get set back to zero the time the clock starts from the beginning. This is a much larger text because I think it's a huge mainstay in very specific philosophical difference that we can put for these patients compared to our other acute care admissions. That we focus our assessment of their pain severity on how their pain is impacting function. And we're not focusing on pain scales, and we're not asking for pain scores daily. So how is pain affecting sleep, and how does this change during the admission? Perhaps it's affecting admission going to school, or perhaps they're doing school while they're at CHEO. Are they able actually to go to the bathroom? Are they able to turn in bed? And are they able to complete the tasks by physiotherapy? And this is how we can assess the success of our therapies. And then we also really encourage that discharge plans are not based on pain scores. They're based on function, and the acute pain service, and if the chronic pain service is involved, can certainly provide guidance on this. I know this is very challenging, but just wanted to present it because this, when possible, this does very significantly support our patients, that we can have continuity in healthcare providers. And I do say during the week and off hours. And what I mean by this is that whenever we can have one person from the team seeing the patient or family every day, that does provide consistency. And then also off hours. As we already mentioned, these patients can be very complex. And so when we get a very junior trainee going in to see the patient during a crisis, and then things can change, the messaging can be different, and this really sets us back. So I'm not saying any of these things are easy, I'm just presenting things that we found to be successful. For our patient with a gunshot wound, we were able to have a nurse practitioner who was able to oversee the long term of their admission. So they were present over multiple weeks. And we found this to be very, very helpful because as the physicians, from what I understand, there's weekly changes in who is supporting the CTU, and having that overarching support of coordinating care and also the knowledge base for that patient. For her was very successful, and we do find in these patients in general to be successful. It also builds trust with the family, and it's consistent with trauma-informed approach, and as we already said, avoids variability in messaging. Multi-D meetings are very important. We've just described it as a multidisciplinary approach. We all need to be on the same page, but we want to try and tailor them so that once we've completed our investigations, we've all come forward with an understanding of what we're dealing with, we create a plan. After that point, frequent multi-D meetings aren't helpful. So certainly to update new team members on what's going on, that can be useful, but we don't need to change the approach on a very short-term basis with these type of conditions. And as I would assume would be kind of what I think would be assumed in this situation. The multi-D meeting has to include all members of the team that who is presenting today. So it has to include physiotherapy, psychology, and psychiatry when they are involved in the care of the patient. So I'd like to go into a little bit more about a few other details about what is our 3P approach. What does this look like in these patient populations? So when we look at the first P, pharmacology, the analgesia medications, as I've already mentioned, we like to have regular acetaminophen and NSAIDs in the beginning. For the acute pain service, our preference when appropriate is celecoxib because it's given every 12 hours, and this can minimize pill burden, which can be very pronounced with these patients. A common muscle relaxant for us is baclofen. And then we do have very common neuropathic pain or central sensitization medications. So you may see pregabalin, gabapentin, amitriptyline, and an SNRI is often very helpful as well. The more intense therapies, if required, and we did see our one patient who required the peripheral nerve block, and then our second patient where ketamine infusion in the very beginning was very helpful to get acute control of the pain while we were fast titrating up our pregabalin. And once we reach our therapeutic goal, then the ketamine was able to be removed. Opioids can be helpful in some situations, short-term, specifically to help with mobilization. But if a patient says IV opioids are the only thing that can help them, just please try to be very careful before we label patients as being opioid seeking. It's a very complicated situation. And as I mentioned, sometimes these patients have been dealing with poorly controlled pain for a long time. And so if they are only responding to the anxiolysis that they get with that IV bolus, it may actually be a cue for us, either that their just pain is poorly controlled, or that we may actually have a primary anxiety problem that may need its own therapy. And that once we are able to control these two things, this need for the IV opioid will go away on its own. So it's complicated. Sometimes it suggests that there's a concern with developing opioid addiction, but it's not a direct connection. And opioids really have terrible side effects. It is awful to take a patient who has significant severe chronic or just persistent pain and then give them constipation, abdominal pain on top of that. For our allied health for physiotherapy and BNCL, just a very bird's eye view, and I will be giving a few extra slides on each area after this. Our physiotherapy services are very supportive or very helpful for mobilization and function if that is impaired, with the goal setting approach that I've alluded to. And then BNCL includes both our health psychology and psychiatry teams. Our health psychology teams are helpful in so many ways. Pain coping skills are very important for our patients to deal with the intermittent spikes and pain crises. And these can be as effective as a medication, or I would say more so. So this is something to give a very high level of importance to. They can also help with giving us a sense if there is untreated anxiety or depression, because if these two conditions are present, or untreated mental health condition is present, it prevents us from ever being fully successful in pain management. And they can also get to know the patient very well, as we've already discussed, the specific nuances of each individual patient's life, their own individual and family challenges and barriers, so that we can give very focused treatments and supports. And as our patient with having his dressing changes with his autoimmune disease, once we were able to determine what that individual patient and father's stressors were, then focused treatment and supports were helpful for supporting discharge for that family. Our psychiatry colleagues are very helpful when we're having these severe dysregulated behaviors for supporting a recognition of such and diagnose and prescribing or suggesting dosing. And then also if we're having persistent anxiety and depression that are preventing moving forward with our multi-D therapy, then other therapy options and medication options or dosing is very often appreciated from there. And not to forget a child life. As we discussed before, some of these patients love being in hospital and they completely lose any sense of having a daily schedule. And with severe pain, this can also be lost at home too. So having child life actually create a daily schedule for our patients is very important. They can support them doing enjoyable activities that are present at CHEO, and then also support adjustment to the hospital, which can be difficult for some patients and families. Looking more specific at physiotherapy, there, as we already discussed, the help is in for goal setting. What needs to happen from a function standpoint to go home, like climbing stairs. And as you can see, the pictorial representation on the right side of the screen shows exactly that, and how they actually use a stepwise approach to reaching the final goal. So first we get out of bed, then our goal is walking to the washroom, then our goal is walking in the hall. And the benefit of this for the patient is obvious, but also the whole team can praise the patient when the small goal is met, and it helps us stay on a focus of function rather than pain scores. So we, again, focus on successes rather than a persistent failure. One request that we've had from our physiotherapy colleagues is that sometimes it's not uncommon for these patients, we've already discussed just in their admission, they can have increases and spikes in their pain. But oftentimes, even if there's been a period of immobility or there is pain directly with mobility, they may need to have a specific PRN medication to support participation in physiotherapy. So an as-needed analgesic is often very helpful. And if there are dysregulated behaviors, we can also use 2 pharmacologic therapies at the same time to support participation in physiotherapy. And common analgesics for us would either be tramadol, hydromorphone, or morphine, small dosing, but again, timed to specifically support function. And then there is a request that before we discontinue any of these PRN analgesics, to always touch base with our physiotherapists to see if this will negatively impact the patient's progress in their physiotherapy. Our health psychology team, and this was Dr. Maris supported me with this slide as well. And so any questions or concerns, I know that she is here to support answering for this. But there's the assessment of mental health and psychological contributors of patient and family presentation, which are very important to tailoring a therapy plan for them. And they also get to know the patient and family very, very well, to have an individualized case formulation from a biopsychosocial framework to drive treatment recommendations. The role of the health psychology team is for evidence-informed interventions. Psychoeducation about pain and mind-body connection are very helpful and very important for our patients and families. They take away the fear and the uncertainty that something terrible is being missed, and they help it narrow down to be something that we understand and we can actually make a plan to deal with. They help with cognitive and behavioral pain distress management strategies. So, my poor anesthesiologist and pain physician phrasing is pain coping skills. But these, again, help the patient in the moment deal with stress and give them a sense of control. They support emotion-focused intervention, and they provide individual sessions with the patient, parent only, and the combination for family sessions. And then this is one of my favorite things, where there's actually a patient who might be having difficulty during physiotherapy for anxiety, fear, pain with movement. And when the physiotherapy and psychology sessions can be combined, and it can be very, very effective to help our patients pass through a roadblock. And our health psychologists also discuss school reintegration plan, because often when our patients reach us for requiring admission due to pain, this is a significant barrier to them getting back to their lives. They can provide time-limited outpatient follow-up, or they can refer to community or hand over to chronic pain team, depending on the scenario. And this is done by a case-by-case basis. And any questions for that, I'm sure Dr. Maris would be happy to answer after the presentation. So this was another slide that she requested we discuss of when to involve psychology. And there are a lot of invalidating phrases we already alluded to. So even if the scenario isn't as severe as I'm describing for this talk, even invalidating phrases can be very helpful to involve our health psychology colleagues. So phrases such as "you're overreacting," "it's not that big of a deal," "don't be sad or stop crying," caregivers apologizing to staff or other patients for their child's reaction, or not believing that the pain requires support. All of these features here can be a cue for us to involve health psychology. So when things get to be a bit more intense for management, we're looking at dysregulated behaviors. So how do we know, okay, well, maybe this is normal, and maybe this is actually something that is pathologic that requires its own intervention. So this is when we might be considering antipsychotic dosing or dosing of an antipsychotic medication, and where we may or may not require direct consultation for psychiatry for this. And this is when our patients are experiencing high levels of distress and behavioral regulation, and it's to support the patient, but also family, also healthcare services. This is such a challenging and destructive component of a patient's presentation. So I want to be very careful with the idea of pain that appears out of proportion to the injury, because any neuropathic pain gives that impression because we cannot see the injury. We don't see an open fracture. We don't see it. And so it might be for our patient who had her spinal cord trauma that she looks fine, but her pain is severe and she was having these intermittent tics. And so we have to rule out neuropathic pain. We have to get good therapeutic intervention on board before we can use this as a guide for dysregulated behavior. However, a change in the patient's personality or behavior that's not an escalation of previously present anxiety, this can be a concern. Family says the behavior is new or different from baseline because our 7-year-old patient did not swear at his family and at others and strangers and hit them with things, who had osteomyelitis. So this was quite new and different for him, and an inconsistency in the pain behaviors. And as well, if you do see self-harming behaviors, these are all little things that come up and say, this seems like it's a dysregulated behavior associated with the pain. The duration as well, and also when we are giving dose-appropriate analgesic medications, and I just speak back to when if it's undiagnosed neuropathic pain, the diagnosis first has to be on what type of pain are we treating and are we giving the right therapy. But it's not normal for patients to scream for 40 minutes, for an hour, or 2 hours. So that prolonged pain crisis, even when we're giving our usual medications or medications that we feel should be effective, if they're not working, this is another cue. And when the behaviors are very loud and disruptive and difficult to tolerate by surrounding patients and healthcare staff, this can give you a sense that this may be a dysregulated behavior associated with the pain. So we've already discussed that it's a barrier to engaging in health psychology, physiotherapy interventions, as we saw with our 7-year-old patient. And the cycle needs to be interrupted to help the patient family move forward. But we have to be very careful in how we actually bring forward the idea of involving mental health supports to a family in pain crisis. We don't want to give them the sense that the pain is all in your head, this is only a mental health disorder. And we have to frame the recommendation using non-judgmental language. So Dr. Maris has given us this example, and I'll read it out because I do feel like it's very helpful. We know your pain is real and you're doing the best you can. Sometimes pain can be so overwhelming and difficult to deal with, and sometimes it gets people feeling stuck in their recovery. We found that involving support from our other team members, such as psychiatry and health psychology, can be helpful to get you unstuck by discussing ways to help you feel better and better participate in your physiotherapy. And one of our other psychologists on the chronic pain team often tells patients that just like we can have a coach for soccer, a psychologist can be a pain coach to better help you cope with better pain and emotions. So there are ways of presenting this in a non-judgmental way that patients can feel like we are helping them and that there are very real things and very good things that we can offer them for support. So it's important that we understand that pain and dysregulated behaviors are conceptually connected, and it really depends on that individual patient. And that's why having a solid case formulation can help us as providers understand that individual patient's pain-related distress as being normal for them because of their own life experiences. So examples for this patient may have had a specific adverse childhood event. They may have a specific neurocognitive profile, learning disorders, a very specific attachment style or temperament. They may have pain catastrophizing. All these things will impact how this individual patient presents with their pain. And it may be that for them, the only way they can is with a behavior that appears dysregulated. So while we have to know that from a conceptual perspective, from a pharmacologic therapy perspective, they need different treatments. We cannot treat a dysregulated behavior with an IV opioid. So that's why we understand where the patient's coming from, but if pharmacologic therapies are required, that's when we need to actually have a separate therapy. You can have a PRN medication for the pain, but also a PRN medication, or as dictated by psychiatry, for our one patient was a regular dosing that can be taken to support how they are managing with their pain crisis or with the scenario at the time. And both medications may be useful for physiotherapy and supporting the patient mobility. And for our patient with the dressing changes, they were very helpful for him in the moment, because his anxiety around the pain he was expecting with his dressing change was becoming very disruptive for him. We can try benzodiazepines, but just to be aware that they do not treat the dysregulation as we did see with our 7-year-old. And that it's also very important for us as healthcare providers, as well as our patients, to understand that the prescribing of the antipsychotic is meant to be temporary. This is a very intense period when the patients are in crisis, and they're in crisis because they do not yet have the coping skills, community supports, and other things. And so it's there to support them while they are learning the coping skills, while we optimize treatment of other comorbidities, and while we're putting community supports in place. And it's really to avoid representation to the emergency department and readmission to hospital because the family can't cope. Because the goal is, with all the other interventions we're putting forward, eventually the patient will no longer have a dysregulated emotional response to experiencing pain. This slide is from Dr. Jovanovic as a support, just to help support our the admitting physicians that antipsychotics can be prescribed without a consultation to psychiatry, as you're all aware. These are the 3 most common ones that she wanted to put forward, with suggested dosing, as well as a caution for complications and side effects and onset time. So this not being my specific area, I don't want to speak too directly about them. I do believe that I at least saw Dr. Ritzko on the call, and I believe Dr. Jovanovic is here as well. So if there are any questions around this, I believe that they are here to support us for that, for answering questions around prescribing of these. But from what I understand, this is not something that requires psychiatry involvement if your comfort is there to use this for your patients from the beginning. But of course, if you're in doubt, their service is very clear. Do not hesitate to page your psychiatry colleagues if you have a question. The request is to have it actually as a direct conversation, a phone call, and not to chats and messages. And I'm sure we would all appreciate this when we're looking at what kind of consultations we require. But also to get the best benefit for helping our patients, that it's helpful to have a well-formulated question. So I like diagnostic clarification for a patient with these specific symptoms and the absence of a previous medical history, or you're trying to get support on pharmacologic management with the previous diagnoses of these conditions and escalation in this specific condition or situation. Just to remember that the supports for staff are also very important. So we're supporting our patients, but these can be very, very difficult scenarios. Our staff supports, we have nursing supports, physician supports for PEAK program and physician support programs. And then also I personally have had a patient who was quite aggressive to me, and having patient experience come into the mix was a good support for me. And then also just debriefing after we've had challenging times. And then for supports for our patients, we don't just give them excellent care in hospital and kick them out with nothing. Certainly if they require continued mental health support, the NCL can be involved in coordinating that. And then we also have the one call, one click for accessing and putting in a consultation for centralized mental health supports. So thank you for your time. I think I'm just right before my limit. So my take-home points are that patients with severe pain, with or without an organic diagnosis, it's distressing for patients and their families, as well as us in the healthcare situation as healthcare providers. Having a standardized approach that I've presented and I hope has been helpful for you to learn about avoids over-medicalization, where we can focus on function instead of pain scores. Having early involvement of the multidisciplinary team with consideration of psychiatry involvement as required is very important. and that if we can recognize the dysregulated behaviors as being conceptually connected, but needing a different tailored pharmacological approach. So I'm sorry I spoke so quickly. I obviously had a lot I wanted to share, but thank you for your interest, and I believe this is the time to take questions.
Excellent. Thank you, Deb, for that excellent talk on a topic that we all have experience with, and we will open for questions. And there's two right now. First from Melanie Bichard.
Hi, thank you so much for a really excellent talk. I work in the emergency department, and sometimes it's hard to tell whether or not patients should be admitted. So any guidance you can give would be great, because sometimes it's pretty clear where there's been a clear escalation and complete lack of ability to cope at home, but other times they're more just languishing, like barely attending school, hardly doing activities, but there's been no acute change. And oftentimes we'll refer to the chronic pain service, but that can be a long wait as well. So I'm wondering if you have any guidance for when it might be appropriate to admit these patients, especially given that beds are such a hot commodity these days.
So thank you for an excellent question. I have a very skewed view on this. If there's diagnostic uncertainty and we think that there is something that can be intervened upon, where we can give a specific therapy that can actually alter the pain trajectory, that I think is very important, whether that requires an admission or not. Otherwise, I would really wish none of these patients to be admitted, because I just feel the inpatient status is very difficult for them and actually harms them. We do have a transitional pain clinic that myself and our nurse practitioner, Brenda Mortelli, run. We don't have it very often, but we are hoping to get more resources as we're hiring another acute pain service nurse practitioner. And our clinic is one where we have taken referrals from Emerge, and we just had one this past week, and we will take patients who have a very similar scenario for what you're describing, and we can at least start pharmacologic therapy, do the pain education, and then give prescriptions and direction for outpatient physiotherapy and psychology as required. So when appropriate, that would be my first thought, is a consideration for the transitional pain clinic, and to avoid admission on that perspective. So I hope that answers your question.
That's awesome. How do we refer to the transitional pain clinic? Is it a separate order, or is it also?
It's the same.
Okay,
it's the same
amazing.
as the chronic pain.
Thank you.
Mm-hmm.
Great. Anne Rowan-Legg.
Listen, thank you very much, Deb, for a great talk, and to the team, and to the work as an inpatient physician, to the excellent work that the APS service does on the ward and to help support us. And I think in hearing the big things from my end that I've heard loud, clear from your presentation as well, is the continuity is a real issue on the ward for all sorts of, like, all the team members. I would say maybe save for the APS representatives are changing over frequently. And also the inpatient versus outpatient part that you highlighted through the presentation, and Mel just brought up as well. And I guess I just was wondering, that transitional pain clinic was new to me too, and I'm really happy to hear that is occurring, because that's what I feel like I wrestle with as an inpatient person. That things are going to sort of potential for falling apart when they go, because their inability to access physiotherapy or psychology and all the rest. So I feel like that's a huge development, and I guess I'm just, it's less of a question than lending my full support that way. That'll be really helpful for these kids and family, because I don't think the inpatient environment is necessarily ideal after a certain time in their course. So thank you.
Thanks, Anne. So the only thing I will say is that Brenda and I don't have access to allied health. So in our clinic, it's mainly medication. And we refer to one call, one click, or give suggestions for families on prescriptions for accessing at least their insurance coverage for outpatient psychology and physio. So that is the one limitation that we have. But at least I find the psychoeducation and medication can make a big impact for these patients. But as you alluded to with the allied health, lack of that is limited that we can do. But we try.
It's okay, Deb. I'll just add a little piece around the psychology follow-up in the transitional pain clinic. So from the BNCL side, sometimes on a case-by-case basis, we can provide very kind of time-limited psychological follow-up for some of those patients being followed by the transitional pain clinic. And it's more, you know, for those vulnerable families, kind of thinking secondary prevention, right? So if a few targeted sessions, or even if they're, you know, outpatient physio is there as well, and we have those joint sessions, if that can prevent or, you know, slow down the transition from an acute to a chronic pain presentation, then it's worth at least having the discussion with whatever psychologist has been involved or psychiatrist involved in the inpatient.
Thanks, Roisin. And then there's a few questions in the chat we can talk about. So Roisin first.
Thank you. It's a super helpful talk to have, because as you said, these are really challenging cases. And I think having a kind of overview of the multi-D approach and what works is helpful. I just wanted to, this might be like dispel the myth kind of question, but I've run into situations before where consulting APS, when it's a case of it is not acute pain, it's more of a picture of a patient who's been struggling with pain for a while, that the feedback has been that this wasn't under APS umbrella, that it would be for chronic pain team as an outpatient, which isn't helpful when the child's sitting in the hospital, of course. Is that an old situation? Is that changed, or is that something that we should continue working on dispelling if we come across it?
So it's very challenging. I think that's something that we have constant communication between the acute pain service and the chronic pain service, because sometimes the acute pain service just doesn't have much new to offer, because so much of what they need is the pain education groups that the chronic pain service offers. So that's something that I think certainly we can come in and speak to. And I think that's whenever the inpatient service is having challenges with this, I think it's always good for us to know, so the two teams can keep talking amongst ourselves to try and find solutions for the patient. But sometimes when medications aren't the only thing and time is really what's needed, the acute pain service can have limited benefit. But I do think that we should always be involved. We should always be present, and we should always be able to give advice. And that's something for us to take back on what our messaging is and try to kind of tighten that up and be clear for you guys. So I do appreciate you letting me know about that.
Right. And my other thought was just that sometimes it feels a bit piecemeal trying to involve all the right people. I wonder if anyone has any ideas on how we can identify, like, hey, this is a patient that needs all these services from the get-go, and to have a coordinated response as opposed to trying to kind of draw each piece individually. I mean, that's just a thought, but not that I have a solution to, but that to me, it would help get the right services involved earlier in the course. I don't think there's any feasible answer to that, just a comment.
Fair enough, thank you.
So I'm just going to go to the question in the chat from Rada, and then we'll go to Melanie. So from Rada, she's asking, saying a great talk. Where does somatic symptom disorder fit into this conversation?
So we're talking about like a functional neurologic disorder, I'm assuming. That's a whole other topic. I think in the 2 minutes, I don't know if I have a good answer for you. It's certainly part of it, but I think that it follows secondary to all the assessments and involvement of the multidisciplinary team, because I think that disorder has to be, the diagnosis can only come once we rule out certain conditions, once we've given good therapeutic options available. And so I think that's something that can be looked into, but it still needs the acute assessment, intervention, and diagnosis. And then we move into that, and it has its own therapy plan. So it's part of this. It's kind of like on the extreme end of the bell curve of these patients. I still think that all these services are important in being involved initially to eventually get us there. But I don't know if that answers your question. But yeah, they are a little bit more challenging.
Thanks. And Mel Buba.
In the last minute. Thank you very, very much for an excellent presentation on a difficult topic. Actually, Roisin set me up perfectly for this, because I was going to ask and perhaps suggest if there's an admission order set that could include all of the potential consults that should be put in for these patients, some medication suggestions so that we are choosing the right medications the first time, celecoxib over NSAIDs, some even with the antipsychotics that were suggested, some suggested dosing and indications for those medications that might help avoid sort of that chaos at the beginning of an admission when we're just struggling to figure out the right things to do and the right people to call. And if such a thing exists, wonderful. And if it doesn't, the inpatient team would be very happy to work with your team in putting something like that together. So thanks so much for all the work you do. Really appreciate it.
Thank you. Appreciate that. I think that would be definitely a further discussion would be helpful. Right now, we were just thinking of policy. So just because each case does need to be tailored, but I think further discussions could really help us with that.
Excellent. And that brings us right to 9:30. So thank you for an excellent talk, and thank you to your the excellent team for this care. It's really been really great, and I think this talk really will help going forward these patients immensely. So thank you all again.
Thank you. Thanks everyone for being here, and again, thanks to the full team.